Ladies and gentlemen, it's an honor to introduce my dear professor, Professor Dr. Naveen Gaddu, and we will start Amgen Symposium titled Bone Health in Metastatic Solid Tumors. Please, Professor Naveen Gaddu.
Good afternoon, everybody. My presentation is recorded, and here it is. I welcome you in our 7th Ancient Shams University International Clinical Oncology Conference, and I thank the organizing committee and Amgen company for inviting me in this symposium. Today, I will speak about the bone targeting agents in metastatic solid tumors. And also avid for metastatic solid tumors. Unfortunately, the overall incidence of bone metastasis is not known, but all of us know that there are some tumors that more avid for metastasis to the bone, like the breast, prostate, lung, and bladder. If we look here that there was a study recruiting more than 4,000 patients, and they found that the incidence of bone metastasis on those patients who are presenting with metastasis, it may reach from 65 to 75%. You can imagine that a very large number of patients are presenting to us with this bone metastasis. And unfortunately, once the patient is diagnosed with bone metastasis, the median survival after developing this metastasis may reach just 20 to 24 months. What about the complications of bone metastasis in breast cancer? We have the skeletal-related events that it may be in the form of radiation, that this patient may need radiation to the bone, or pathological fracture, spinal cord compression, or surgery to the bone. In the breast cancer, these skeletal-related events, for example, more than 50% of the patients presented with bone metastasis, they may have pathological fracture, and 53% may need radiation to the bone. For the prostate cancer, maybe the percentage differs, which is the highest percentage would be need for radiation to the bone, and 1/4 of the cases may have pathological fracture. 8% only may have spinal cord compression, and 4% surgery may be done for the bone. Okay. For the cancer-related bone disease in solid malignancies, this bone disease or the bone loss may be induced due to the treatment of the cancer, for example, hormonal intake that leads to bone loss, or the cancer itself, it induces bone disease in the form of these metastases, and all of this lead to decreased bone strength. Then skeletal-related events occur. The incidence of these skeletal-related events in the cancer patients in general may reach 64% in the breast cancer, and 50% in prostate cancer. And this, of course, percentage is a very high percentage. What are the consequences associated with the skeletal-related events? It may be in the form of the patient has severe pain. Of course, you will be suffering from poor quality of life. This may necessitate the entrance and the hospitalization with increased medical costs, and also this in turn would lead to reduced overall survival. What about the effect of the skeletal-related events? For example, the pathological fracture, what's its impact on the survival? If we look here that the patient, the breast cancer patient with pathological fracture, may have a increase in the risk of death, which is reaches 32%. For the prostate cancer, it may reach 20% increase in this risk of death. The patient will suffer from pain with the increase the need of the use of opioid. Also, this would affect the mobility and the quality of life. The patient having the skeletal-related events would suffer from hospitalization. And once he experienced this skeletal-related event, this would require far longer hospital stays. But this is the case, unfortunately, and we have to find a solution. Okay, what is the management? This is the solution, the management of the skeletal-related events. We have two main agents that we can use, the bisphosphonates and the denosumab. First, I will speak about the mechanism of action of the bisphosphonates. The bisphosphonates, it accumulates in the bone matrix at the site of the bone turnover. It will be released by the osteoclast, where it inhibits the osteoclast activity through inducing apoptosis. For the denosumab, the mechanism of action, it differs, where it inhibits the rank ligand. What is this, the rank ligand? First I will speak about the denosumab. It is a human monoclonal antibody that binds to this human rank ligand. And then, as you see here, this rank ligand, it is expressed by the osteoblast, and it promotes the bone resorption. So this green granules, as you see, it is this rank ligand. It is released from the osteoblast, and it goes and it promotes the bone resorption. How this happens? This happens, like you see here, that this rank ligand is, as you said before, it is released or secreted by the osteoblast. It is a very essential mediator for osteoclast formation and function survival. This receptor, it is expressed on the surface of the osteoclast. So when this rank ligand binds to its receptor, which is present on the surface of the immature osteoclast, it allows maturation and differentiation into multinucleated osteoclasts that leads to increased bone resorption. To regulate this bone formation by the osteoblast and the bone resorption by the osteoclast, so the osteoblast releases or produces what's called osteoprotegreen. This osteoprotegreen, it binds to the rank ligand, and it prevents activation of the osteoclast, so stop the bone resorption. The osteoprotegreen neutralizes the effect of the rank ligand, as I said before. And in the healthy state, there is a must that there will be a ratio of the rank ligand and the osteoprotegreen in balance. Both of them are in balance. This is up in the center. But if the rank ligand decreases, there will be an increase in the bone loss. And if the osteoprotegreen decreases, this prevents bone loss. So both the denosumab and the bisphosphonates, they break this vicious cycle. The denosumab, it sequesters this free rank ligand. So it inhibits the osteoclast formation, function, and survival. While for the bisphosphonates, it inhibits the enzyme pathway, which is essential in this pathway, and causes osteoclast inactivation and apoptosis. There are some unmet medical needs that even with the use of these treatment options, still there are some unmet medical needs. First, I will speak about the delay and or the reduction in this skeletal related events. There are 3 identical randomized double-blind controlled trials. They recruited the cases with bone metastasis due to breast or prostate or other solid tumors or multiple myeloma, and they gave these patients either denosumab with the placebo IV every 4 weeks or zoledronic acid with a placebo every 4 weeks. And their primary endpoint was the time to the first on-study skeletal-related event. When will the first skeletal-related event appears? This is the patient characteristics with the, as we see that there were some patients have visceral metastasis and also the male and the female percentage was nearly equal in both arms. There are different types of cancer cases, like the breast, prostate, non-small lung cancer, bladder, rectal, colon. What did they found? They found that the risk reduction in time to first skeletal-related events, it consistently favored denosumab across the tumor types. As we see here, for the breast cancer, there is a 18% risk reduction. Also for the prostate, it's the same. And if we look on the curve, we will find that for the breast cancer, it was not reached the time to first skeletal-related event to occur. But for the zoledronic acid, it was reached. For the prostate cancer, it was 20.7 months versus 17 for the zoledronic acid. And for the other solid tumors, it was 20.6 months versus 16.3 for the zoledronic acid. So they concluded that the time to first on-study skeletal-related event was 21.4 months versus for the denosumab versus 15 months, with a difference of 6 months in favor for the denosumab. Also here, there are superiority that was maintained across the 4 categories of the skeletal-related events, whether the pathological fracture, radiation to bone, spinal cord compression, or surgery, in favor for the denosumab. So we can find that the denosumab, it has effective treatment, and it reduces the risk to the first on-study skeletal-related event, regardless the age. Also, there are no difference between the denosumab and zoledronic acid groups, either for the overall disease progression or for the survival. What about the markers of the bone metabolism? We have 2 main markers I will speak about, which is the first one is the N-terminal cross-linked telopeptide. It is primarily made by the type 1 collagen, and it is released when the bone is degraded by the osteoclasts. It can be measured either in urine or serum. It's present in high level, indicates increased levels of bone resorption. The other marker is the bone-specific alkaline phosphatase. It's secreted by the osteoblasts, and it contributes to new bone formation. Also, it increases in case of bone metastasis. It's measured in the serum. High levels of this bone-specific alkaline phosphatase indicates increased levels of bone formation. There was found that there is a median change from baseline in these markers of bone turnover at week 13. And this median change, it was for the bone-specific alkaline phosphatase, it decreased from baseline by 39%. In the denosumab group, while it was 32% in the zoledronic group. And this, you can see, for the elevated marker is associated with the poor outcome in prostate cancer with bone metastasis. Yes. Also, it significantly, we find that significantly fewer skeletal-related events with denosumab versus zoledronic acid across the different tumor types, as you see here in this curve. What about the overall survival improvement in patients with lung cancer and bone metastasis treated with either denosumab or zoledronic acid? This study, they tried to recruit those patients with lung cancer and having bone metastasis. They randomly gave them denosumab subcutaneous, 120 milligram every 4 weeks with plus placebo IV given every 4 weeks also, versus zoledronic acid 4 milligram IV every 4 weeks with placebo subcutaneous every 4 weeks. And these lung cancer cases were having two main subtypes, the non-small and the small lung cancer. As we see here, that denosumab was associated with improved overall survival versus zoledronic acid in those patients with lung cancer, having a median overall progression, a median overall survival, 8.9 versus 7.7 months. What is the mechanism of this observed survival benefit? How did the denosumab achieve this more overall survival? How did this happen? The mechanism is currently, it's not known, but there are possible explanations. One of them is a direct or indirect anti-cancer effect of the denosumab, or that secondary consequences of the skeletal related events reduction due to that it succeeded to reduce this skeletal related events, so it can lead to better overall survival. This is just a scheme for the potential effects of denosumab on lung cancer outcome. As we said, it can be direct or indirect. It has a protective effect on the bone. Also, it has an anti-cancer effect. The direct effect through inhibition of the RANK ligand, as I said at the beginning, which may induce apoptosis. The indirect through targeting the osteoclasts and disrupting the interaction between the tumor cells and the bone microenvironment. Pain. Of course, those patients with bone metastasis, they have pain. And there are fears of cancer patients with metastatic disease from both of them, the pain and the death. Why? Because unfortunately, those patients who are presenting to us with bone metastasis, we find that 64% of those patients report pain, they have pain. And unfortunately, 1 in 3 of those patients report significant pain, which may be moderate or severe pain, okay? The majority of those patients with pain reported, unfortunately, this may lead to interference with the quality of life and enjoyment of life. The denosumab has delayed pain progression by almost 2 months versus the zoledronic acid. And this, of course, for the patient is very important that we succeed in having a difference in delaying this occurrence of the pain. The second point for the unmet need is the renal toxicity and acute phase reaction. Okay, what about the renal impairment? They found in this IRMA study that For all cancer cases that they recruited that may reached nearly 5,000 cancer patients, 57.4, that's to say 60%, nearly 60% had renal insufficiency. So renal insufficiency is present, can be present from the beginning in those patients that have bone metastasis. So I have to take care that what I'm giving of treatment, it should be have no renal impairment or renal toxicity, because I don't need to add more renal toxicity in these cases. As you see here, that the renal toxicity in breast cancer patients treated with denosumab versus zoledronic, here the adverse events potentially associated with renal toxicity was 8.5% of those patients treated with the zoledronic versus 4.9, nearly 5% treated with the denosumab. Also, those patients have a renal adverse event. Among those patients with baseline renal clearance was 20% for the zoledronic versus 6% for the denosumab arm. What about the acute phase reaction? It was significantly lower with denosumab. As you see here, it was 8.7% versus 20.2% for the zoledronic arm. Lastly, the efficiency in the treatment. The quality of life. It's very important because as we see here, that had a higher proportion of patients on the denosumab had a clinically meaningful improvement in the quality of life versus the zoledronic acid. And as we see here, that there is about 10% improvement in the quality of life with denosumab versus zoledronic acid. What about the toxicity? If we go for a comparison of the bisphosphonate versus denosumab, as we see here that denosumab subcutaneous versus bisphosphonate intravenous, both of them have osteonecrosis to the joint. Also, both of them may lead to hypocalcemia, which is a very important point that we have to take care when we are treating these patients with bone metastasis and giving them these agents. You have to do before every time you are giving this agent, you have to go for the renal function tests and also for the calcium. The renal toxicity is relatively higher in the bisphosphonates because it is eliminated from the kidney. This is not the case for the denosumab because it is not metabolized in the kidney. The flu-like symptoms also, it is present with the bisphosphonates. To wrap up, both bisphosphonates and denosumab are effective. They are effective in preventing the skeletal-related event, in palliating pain from bone metastasis, and also in preventing the development of pain. There are two distinct choices for the different toxicity profiles. As I said, the zoledronic, we will have flu-like symptoms, renal toxicity, osteonecrosis. For the denosumab, also we will be faced with osteonecrosis or hypocalcemia. And it is our choice, or it's not only my choice, it's the patient's preference to receive subcutaneous versus intravenous agent. My final take-home message is the denosumab provides meaningful additional benefit over others, where it demonstrated superior skeletal-related event prevention. In 2 points, that it's significantly longer time without the skeletal-related event. As I said, it's postponed the time for the appearance of the first skeletal-related events. Also, it significantly showed fewer skeletal-related events. Also, the significantly reduced mean skeletal morbidity rate with the denosumab versus zoledronic acid. And the pain progression, it is significantly delayed with the denosumab versus zoledronic acid. For overall survival or disease-free progression, they are comparable between these two groups. We can't say that one of them have better overall or disease progression than the other. Thank you.
Thank you, Prof. Nivir, for the very informative, elegant presentation. And now we open the floor for discussion. Okay, Dr. Nivir, I want to ask you, if I started my patient with bisphenols with zoledronic acid, can I, if there is a bone progression, can I replace by denosumab as a second line? Can I use it as salvage?
I think there is no problem so long that the patient is in need for it. You can go for the other one. Everyone is working by special mechanism, so there is no contraindication to use the other agent.
Okay, and regarding the renal toxicity, can I use the denosumab up to which level, or create clearance up to more than 30 millimol per unit, or it has another dose adjustment?
Yes, in spite the data that I said in my presentation that it is not, it has a no renal toxicity, but because it's not metabolized by the kidney, but still we can't go safely with any agent, and still there is some concerns about using it with those patients with having a low creatinine clearance, maybe as you said, the cutoff value 30 mil.
Okay, thank you.
Is
there other questions? No other questions. Okay, thank you, Dr. Nivir, and hoping to see you in the next year. And thanks for the committee for inviting me for this very successful virtual meeting. Thank you.